I'm going to present over the next 8 minutes or so. I realize we're running a few minutes behind my talk, which is I've been asked to address the question, could clinical outcome registries bring us closer to consensus? And two disclosures. One, I don't have any financial disclosures, but I'm really biased in that I want to believe that registry data can bring us to closer to consensus on this question. As many of the presenters have shared that many of these techniques, there's not a lot of good evidence. They haven't been well studied, and as Linda told you, they've changed their technique at Columbia with very little evidence. So would a registry help? I work with this group, and my only regret about being here today is that they're meeting today in Hanover, New Hampshire, and probably right now they're talking about post-op AFib and how to prevent post-op AFib, and I wish I was there to learn about that, but you can't be in two places at once. So the aim of the presentation will be to discuss some of the challenges related to making inferences about cardioplegia solution or myocardial protection techniques from registry data. And what's a registry? As we know, a registry is an organized system to collect uniform data, clinical and other, to evaluate specific outcomes for a population. And if you want to learn more about it, ARC has published a beautiful pamphlet about a registry, and it's a good thing to review. So in that ARC handout, it says that a registry can be used to describe the natural history of a disease, to determine clinical effectiveness or cost effectiveness of healthcare products and services, or to measure or monitor the safety and harm and or measure quality of care. So it looks like a perfect tool for this question about myocardial protection and what solution we would use. So these are three registries that collect myocardial protection data. The NNE was established in 1995, the perfusion registry was, and we have about 63,000 procedures in there. PDU began collecting in 2007, or 2006, I believe, and now you have 20,000 cases, Rob, about 20,000 cases, and Perform 2010 with 32,000 cases in that database. This is the section which what we collect in the NNE registry for cardioplegia variables. We look at the cross clamp. Was the cross clamp used or not? We look at the type of cardioplegia solution that was used. The induction dose, was it a standard solution, and we have in there Buchberg solution because we've used that predominantly in our region in the past. The induction temperature, the maintenance temperature, the routing, which, like Linda shared, is quite variable in the NNE. The timing of doses, we looked at the longest period of time between a dose, between the first dose and a subsequent dose. The proximal technique were the proximals down on coronaries with the clamp on or with the clamp off. Was a hot shot used, and what solution was used for a reanimation solution? And then the total volume of cardioplegia used. So if you look at centers across the region, and these are the names of the centers, the 8 centers, you see there's quite a diversity of the solutions used. These blue ones here are using microplegia. The green ones are using a 4-to-1 solution, and we have one center that's using an 8-to-1 solution of cardioplegia. We can look at different aspects of the delivery. This is an example of just looking at the cardioplegia volume per minute of clamp time, and so we can generate these types of reports. I just put that in there as an example. It really doesn't address solution, the solution used. This is from the PDU registry, their cardioplegia variables that they measure, and they measure bypass time, clamp time, a number of periods of bypass, that's if they had to go back on, the pH stat, alpha stat strategy. Then this drop down here is most of their cardioplegia information in terms of what type of solution and what routing was used, and then the induction temper and maintenance temperature. But those are the parameters that they collect. The PDU collects nearly identical parameters to the NNE registry, a lot of the same. And I spoke with Rob recently, and he indicated to me that PDU is going to begin to collect the same parameters as the perform registry, which will then be the same as the NNE, and we'll have similar data across those 3 registries. This busy slide shows the perfusion down under myocardial protection, the different strategies. And so this is a little bit busier because you have the type of solution and the routing of the solution contained in the slides. So the blue is blood antegrade, the red is blood anti and retrograde, and there you see the variety and variation across centers from PDU. So what can we learn from a registry? So I became interested and decided to query the NNE registry about cardioplegia solution. And the research question I posed is this: is there a difference in risk-adjusted rates of low output failure, afibrillation, long-term or short-term survival between microplegia and 4-to-1 blood cardioplegia? I chose those 2 solutions because we had, as I showed you before, we have a lot of centers using those. Those are the 2 predominant solutions used in our center. So I sent this research question to our analyst, Elaine Olmstead, and she has been an analyst with our database since about 1988, and she is a very experienced analyst. And she wrote back to me and said, I have to say this is one of the most difficult analyses to sort out that I've ever worked on. The difficulties related to confounding are on a couple of levels. She mentions that the exposure or the cardioplegia type is completely tied to the center. You remember those bars, we were pretty consistent in what we did in each of our centers. We used one technique. And when centers choose a cardioplegia solution, they use it on all the patients. So there's almost no variation within centers. It'd be very difficult to sort out the effect of the cardioplegia from the practice patterns at each of the centers. So the problem is, if we do an analysis on cardioplegia solution, there are going to be other center effects. There are going to be other center effects related to how the care is provided there. There are going to be effects there in terms of the surgeons, the operative surgeon, because we know that has an effect on those outcomes that we were looking at as well. So I asked Elaine to look at an analysis that was of a single center, and this is our center's data. And until about 1999, we used 4-to-1. The red represents 4-to-1 blood cardioplegia. And then in the middle of the year in 1999, we switched to the blue here, which is referred to as Quest, which is really microplegia. And we changed the definition, but really from this point on in 1999 forward to this day, our predominant strategy for coronary surgery is microplegia. So I asked Elaine to consider doing an analysis looking at patients from before 1999 and a cohort after 1999, and then looking at a propensity-matched analysis of those 2 groups to see if we could determine if there was an effect from that change from 4-to-1 blood to all blood. And she sent this back to me, and she just pointed out that over time there were so many variables that changed that could possibly be possible confounders. Longer pump time, is this related to mortality? Yes, it is. Significantly related to low output failure? Yes. Significantly related to AFib? Yes. Was there a change over time in MMC? Yes. Potential confounder? Yes. So all these factors were potential confounders which made us not go forward and do that propensity matched analysis because we felt it wouldn't give us the right answer. Donnie led this work, which was published in 2012 in Circulation, where he looked at variation in low output failure across surgeons. And what you see across the bottom here are 32 surgeons in the region. And the black line here, this is the predicted low output failure, the expected low output failure for the patients for each of those surgeons. And what we found was that some surgeons had a poor, higher rates of low output failure than predicted. And so in this analysis that Donnie did, it pointed out the variation that's related to the operator or the surgeon. And what we reported was 42% of the variation in low output failure was related to the patient's disease characteristics, and 85% was related to the surgeon that operated on them. And this is just an analysis that he did. He took this graph and he took the 1/3 here that were the high performers that had very little low output failure, then a middle tercile here that had a rate of 2 to 5.9% low output failure, and then a high rate of low output failure, and tried to look at some of the techniques that they used and the variations that we might be able to distinguish that would help us to know what made the difference between surgeons. And one of the graphics he looked at was the type of cardioplegia. And as you can see here in the low output failure group, the group that was less than 2%, 3/4 of them used blood cardioplegia, and 1/4 used crystalloid cardioplegia. But then if you look at the middle and higher terciles, they used mainly blood cardioplegia. But does this mean that was the component that made the difference? I don't think you can say that. This is simply a signature of how that particular operates. So in summary, I'll say that while myocardial protection strategies are quite variable and undoubtedly important, a number of factors may be categorized as center-related effects. And then there are also the surgeon-related effects that could affect the outcome, and then the patient-related effects. We can adjust for some of the patient-related effects, but I don't think we can identify carefully enough those surgeon-related effects and center-related effects that contribute to those outcomes. So caution must be exercised when attributing a particular myocardial protection technique to an outcome, since center and operator characteristics are strongly related to the outcome, and the myocardial protection strategy is often driven by the center or driven by the surgeon. I do think that registries will have value, particularly if we begin to bring this registry data together. We have over 100,000 cases now in these 3 registries. And maybe the answer will be to look for patterns of practice among centers that have better outcomes and better results. Maybe it will be a combination of things, but not specifically myocardial protection. I don't think we can tease out one. Thank you very much.